you very much for the invitation. It's a great pleasure. It's an honor to be here. It's my first time in Brussels, so I had the chance also to visit the city center for a while this morning. But I'd like to share with you our experience with total marrow irradiation, which I believe is the biggest one in the world, in fact, because so far we have performed approximately 300 TMI procedures, mostly in multiple myeloma. As we all know, autologous transplant is a standard of care for patients with multiple myeloma. It is also the most frequent indication, and is the most frequent indication for autologous transplant, both in US and in Europe. There are some doubts whether double autologous transplant is better than a single procedure in the era of new drugs, but anyway, we know that all patients eligible for high-dose therapy should be offered this treatment option. But the transplant itself, I mean the cells, the grafts, are not curative at all. They only allow us to introduce high-dose therapy that may be either based on chemotherapy or irradiation. Traditional myeloablative conditioning regimens are based either on high-dose chemo or total body irradiation. But in case of multiple myeloma, a worldwide accepted standard is melphalan at a dose of 200 milligrams per meter square. That is considered the standard conditioning for this group of patients. But on the other hand, we know that multiple myeloma is also a radiosensitive disease, and it would be nice to use both chemotherapy and irradiation, provided that we are able to do this safely. Unfortunately, there was only one prospective randomized trials performed by the French group to test this hypothesis. They combined melphalan, but at a lower dose, 140 per meter square, with TBI at a dose of 8 grays level, and compared it to standard single melphalan-based autologous transplants. And unfortunately, they were not able to show any benefit from the combination of radiotherapy and chemotherapy. Moreover, there was even a tendency towards decreased survival after this combination therapy. There were various possible explanations of this phenomenon. First, it was assumed that this combination was too toxic. On the other hand, the doses of both melphalan and TBI could be suboptimal, and therefore the efficacy was also lower than expected. But now we have new tools, modern technologies that potentially allow us to reduce toxicity while maintaining efficacy of irradiation. And this technology I am going to talk about is total marrow irradiation. We know that multiple myeloma is bone marrow disease. In fact, we don't need to irradiate the total body. We may try to focus our irradiation on the skeleton where the disease is located. And this is just an example of such irradiation planning, showing that we are able to do this, in this case with helical tomotherapy, the device that is used in more and more centers in the world. The first group to test this hypothesis and to implement total marrow irradiation as a part of the treatment of multiple myeloma was by George Somlo and the group from the City of Hope in USA. They performed a seminal study published in 2011 in Clinical Cancer Research. In that study, patients aged 18 years or more with at least stable disease after induction chemotherapy were mobilized with the use of cyclophosphamide plus G-CSF, and then treated with a tandem autologous transplantation. The first autotransplant was based on melphalan alone. This was a standard, well-known approach, while after approximately 2 months, they received second autologous transplant, in which conditioning was based on total marrow irradiation alone. This was a phase 1 study, they tested increasing doses of total marrow irradiation starting from 10 grays up to 18 grays to find the highest tolerated dose. Then patients received maintenance based on thalidomide. This was a scheme of irradiation. The first dose level was 10 grays, 1000 centigrades, which means 10 grays, and was given in 5 fractions, 1 fraction per day. The fraction was 2 grays. With escalating doses, they added additional 2 gray fractions afternoon, and with a maximum dose of 11 grays, there were in total 5 fractions in the morning and 4 fractions in the evening or afternoon. The tolerance of this procedure was the primary endpoint of this study, and as you can see, it was quite good. As expected, there were some cases of febrile neutropenia. They were independent on the dose. There was some fatigue, anorexia, more frequent in higher doses, 16 and 18 grays, nausea, vomiting, very few cases of mucositis. In fact, there was no severe mucositis in this group of patients. While the highest doses, 11 grays, were associated with some severe toxicities like enteritis, colitis, and dose-limiting toxicity, which was pneumonitis and congestive heart failure. For this reason, the authors concluded that 16 grays was the maximum tolerated dose, and patients should not be treated with doses higher than 16 grays. Anyway, in this group of 22 patients, the tolerance of the procedure was absolutely acceptable up to the dose of 16 grays. They analyzed also the efficacy of the procedure. The overall survival and progression-free survival seemed quite enhancing, although the follow-up in this study was relatively short. There was a plan to perform a phase 2 study in City of Hope, but they were not able to organize it for some reason. While following their experience, we decided to perform phase 2 clinical trial in our center in Gliwice using the same device, helical tomotherapy, but a bit different way of fractionation. I will show you details in a moment. So the aim of our study was to evaluate tolerance and efficacy of a tandem autologous transplant with sequential use of TMI and high-dose melphalan. This was a prospective phase 2 single-center study. This is how TMI looks in our center. Helical tomotherapy. Patient enters the tunnel while linear accelerator rotates in the tunnel, allowing for a very nice distribution of the irradiation as illustrated in this picture. So we are really able to focus our irradiation on skeleton while saving organs that do not need to be irradiated, like lungs, intestines, kidneys. Obviously, some dose is acquired by these organs and tissues, but it's much lower compared to the skeleton. This was the design of the study. We included patients up to the age of 65 years who had achieved at least partial remission after 1 or 2 lines of induction chemotherapy. At that time, induction in Poland was usually based on thalidomide with cyclophosphamide and dexamethasone, CTD, which could, by the way, affect the efficacy of the whole treatment, but we had no access to newer drugs. All patients were scanned with FDG PETs in order to detect active sites of the disease. Results of the PET scan was then used for planning irradiation. After this PET scan, patients were mobilized with ID-RRC, intermediate dose RRC plus GCSF. This is our original protocol. I will come back to this issue in a moment. Some patients were mobilized with GCSF alone. In contrast to City of Hope approach, we started with the first autotransplant based on total marrow irradiation. This allowed us to really analyze the tolerance of TMI and the efficacy of TMI independent on chemotherapy. TMI was fractionated in a different way than in City of Hope. We use only 3 fractions, 4 grays each. This is a more aggressive way of fractionation, but very friendly because it's only once daily. So we don't need to ask your patient to be treated twice daily, which in some centers may be a logistical problem. Those who were PET positive were given additionally 6 times 4 grays prior to TMI as a kind of boost to increase the efficacy of the whole procedure. The second autotransplant was performed 3 to 4 months later, and it was based on melphalan 200 milligrams per meter square. Some patients could receive maintenance. At that time we had thalidomide only. We restricted maintenance to those with the evidence of active disease 3 months after second transplant, no history of resistance to thalidomide, and no history of thalidomide intolerance. Coming back to the mobilization issue, you may be surprised that we use intermediate dose RRC. This is our original protocol, in fact, elaborated several years ago, but we have a very good experience with it. This is total dose of 1,600 milligrams per meter square, given in 4 doses on days 1 and 2, followed by GCSF starting from day 5. Initially, we used it for patients who failed previous cyclophosphamide-based mobilization. Then we compared RRC with cyclophosphamide in a retrospective analysis showing that RRC is much more effective compared to cyclophosphamide. And this comparison allowed us for successful harvest in 97% of patients compared to 66% after cyclophosphamide. But then we also performed a prospective randomized trial comparing RRC with GCSF alone. In the United States, most patients with multiple myeloma are mobilized with GCSF steady state. So we decided to verify if intermediate dose RRC may be associated with increased efficacy, and indeed we demonstrated it. The comparison showed 98% efficacy after IDRC compared to 70% after GCSF alone. In terms of patients who collected at least 5 million CD34 positive cells per kilogram. Importantly, most of these patients could be effectively mobilized and could collect a sufficient number of cells with single leukapheresis. So we stick with the IDRC mobilization, and this is our standard of care. The comparison of CD34 positive stem cell yield after RRC and GCSF. So coming back to our phase 2 study, this was the flow chart. 53 patients were screened and mobilized. 3 patients dropped out because of their refusal to continue. 50 patients entered the first autologous transplant. 1 patient dropped off because of personal reasons. This patient was analyzed in an intention to treat analysis, but did not go to the second transplant, while the remaining 49 patients did. 10 patients were treated with thalidomide maintenance. This is the patient's characteristics. Median age 58 years, equal proportion of male-female gender. The distribution of multiple myeloma subtypes, nothing particular. Most patients were in PR, 54%, then 36% in VGPR, and only 10% entered the transplant procedures and complete remission. Results of our mobilization, as expected, it was very, very efficacious, and we were able to mobilize the vast majority of our patients very easily with a single approach. These are data on efficacy. The distribution of CRs, PRs, and VGPRs before the first transplantation. After the first transplants, which was based on TMI, the proportion of VGPR patients increased markedly, and also some patients who were in VGPR entered complete remission, while reversely, the proportion of patients in PR was reduced by more than 50%. After the second transplant with melphalan, only 12% of patients remain in PR, approximately half of them in VGPR, but more than 40% achieved complete remission, including stringent complete remission. So we had some evidence for the efficacy of TMI and for the efficacy of the whole tandem procedure. This is the illustration of the reduction of M protein. After TMI, some patients reduced their M protein to 0. These were our CR patients, while after the second transplant, so the whole tandem procedure, the proportion of those achieving negativity of M protein was, as mentioned, more than 40%. Now focusing on total marrow irradiation, it appeared fully myeloablative. All patients experienced absolute agranulocytosis, but the engraftment was very fast. It was stimulated by GCSF in all patients, but anyway, it was very, very fast in our eyes. 11 days median neutrophil recovery and 12 days median platelet recovery. All patients engrafted. Now looking at other toxicities, as expected, due to agranulocytosis, there were some cases of infections and febrile neutropenia in total of 30 patients, while non-hematological toxicities were really incidental. There were no grade 4 toxicities, single cases of grade 3 toxicities, one patient with anusia, one diarrhea, only one patient experienced mucositis, and 2 cases of hyponatremia. So we were really astonished by the tolerance of this procedure, which was full myeloablative, but very other organ saving. After melphalan, there were some more adverse effects, although still acceptable. More than 50% of patients experienced grade 2-3 nausea. There was more mucositis expected, but still no non-relapse mortality, and only one grade 4 event, which was caused by infection. These are our survival curves. With a median follow-up of 50 months, the overall survival at 4 years was 74%, and progression-free survival 62%. I speculate that these results could be even better if patients received more aggressive induction therapy, at least based on bortezomib. At that time it was unavailable in our country as a frontline treatments. So we concluded from this study that personalized conditioning with 12 grave TMI without PET-guided boosts is characterized by very well excellent tolerance while preserves myeloablative potential. The sequential use of TMI and high-dose melphalan is safe. There were no cases of non-relapse mortality. And of course, long-term efficacy requires verification in prospective, optimally randomized trial. And indeed, we designed such trial, which is currently being organized in several Polish centers. This study will include patients with newly diagnosed multiple myeloma after 4 to 6 courses of induction chemotherapy that will be based on bortezomib plus thalidomide and dexamethasone. The randomization will be prior to mobilization. The standard reference arm will receive a single transplant based on melphalan 200 alone, while the experimental arm will receive a tandem transplant as tested in a phase 2 trial, so melphalan and TMI, but in reverse sequence. We are still discussing the need for consolidation or maintenance after either single or double transplantation. There is a big debate if it is really needed or not. The primary endpoint of this study will be progression-free survival at 3 years. We assume increase of PFS by 20%, and with such assumption, the estimated population would be 200, which means 100 per arm. Maybe it's too optimistic, but we don't have so far strong data to calculate it in a different way. If this study would be international, then we could think of bigger patient population. This was about autologous transplants, but we have also some pilot experience with a tandem also allo transplant using total marrow irradiation. This is a pilot experience with only 12 patients so far, but I'd like to share this data with you as well. For allogenic transplants upfront in multiple myeloma, we refer patients who are up to the age of 55 with high-risk disease, which means either high-risk cytogenetics or extramedullary myeloma, which is associated with poor outcome. Obviously, informed consent is obligatory, and patients are explained all risks associated with allotransplant, and this is their decision. On the other hand, this is the only really curative approach still nowadays. Once again, these patients are scanned with PET-FDG, mobilized with IVRC. The first cycle is autologous transplant with 200 milligrams per meter square melphalan, and after 3 to 4 months, patients are submitted to allogenic transplant, which is based on total marrow irradiation, but to ensure immunoablation, we add bendamustine at the dose of 200 milligrams per meter squared on days -5, -4. Those who receive transplant from unrelated donor are also treated with ATG. In case of initial PET positivity, TMI is preceded by boosts to active sites of the disease. As mentioned, so far we treated 12 patients with this method, and the median age was 44. Status at mobilization, either CR, VGPR, PR, stable disease. There was also one patient with progressive disease. Although we try to include patients who are chemosensitive. Conditioning TMI in 12 grades plus bendamustine. 4 patients were treated with allotransplant from matched sibling donor, 8 patients from matched unrelated donor, with peripheral blood social stem cells and immunosuppression as a standard one, cyclosporin A plus methotrexate, and ATG for unrelated donor transplants. With a still short follow-up of 18 months, all patients are alive. Neutrophil recovery after TMI bendamustine is very fast, 12 days. So far we had one failure, which was progression, and therefore progression-free survival at 1 year is 90%. There was no case of non-relapse mortality. We had no acute graft-versus-host disease, grade 2 to 4, and only one case of extensive chronic graft-versus-host disease. It's too early to recommend this approach to anyone, but I'm convinced that such curative way of treating younger patients should at least be discussed. TMI plus bendamustine is a myeloablative conditioning regimen, but very well tolerated, so we call it reduced toxicity, while not reduced intensity conditioning. These are centers in Poland that are collaborating with us, and acknowledgements to my colleagues from Gliwice Institute. Thank you very much. I will be happy to